for the second part of our morning. All right, welcome back. And we're next up for this morning, we're going to hear updates from the GaPQC leadership team. And so as everybody's taking their seats, we can give you updates on the maternal and neonatal initiatives. One of the things that I think is nice is this is an opportunity to hear what the different groups, sometimes for us on the neonatal end, to hear what the maternal initiatives have been working on and vice versa. So I'd like to start by introducing my GaPQC colleagues, Drs. Melissa Kottke and Teresa Byrd. Dr. Melissa Kottke is a professor in the Department of Gynecology and Obstetrics at Emory University. She completed a fellowship in complex family planning and is medical director of teen services and family planning clinic at Grady Memorial Hospital, and the director of the Jane Fonda Center at Emory, which is involved in research and program development focused on adolescent sexual and reproductive health. She also serves as a medical consultant for the State of Georgia's Family Planning Program and the maternal co-chair for the GaPQC. Current areas of research include dual protection, over-the-counter contraception, and ways to improve sexual health for teens. Dr. Teresa Byrd is a native of Los Angeles, California. We're lucky that she moved to Georgia. She received an undergraduate degree in biology, pre-medicine from Florida A&M University and obtained her medical degree from Meharry Medical College in Nashville, Tennessee. Dr. Byrd completed residency training in obstetrics and gynecology at the University of Texas at Houston Health Services Center, Sciences Center. And after residency, she returned to serve on the faculty at Meharry Medical College, where she went on to obtain a master's degree in clinical investigation. Dr. Byrd advanced to the rank of associate professor at UT Health at McGovern Medical School, where she served as both the residency program director and clerkship director. Currently, she is at Wellstar Kennestone as the director of obstetrics and gynecology residency program in Marietta, and her entire career has been focused and devoted to academic medicine, focusing on innovations in medical student resident education, hospital and quality improvement efforts, diversity, inclusion, equity, and healthcare. She's presented at numerous locations, and as an academic generalist has been in cervical intraepithelial neoplasia, minimal invasive gynecologic surgery and gynecology, and she serves as the ACOG District 4 Committee on Health Equity and Respectable Care, the CREOG Executive Committee, the Georgia OBGyn Society Advisory Board, and the GaPQC Maternal Co-Chair and Health Equity Liaison. So we'd like to welcome both of them up, and they're going to give us an update on the maternal initiatives.
Good morning. Thanks y'all so much for being here. Let's see if this works. Dr. Byrd and I are going to work together in giving you the update from the maternal arms. I'm going to do a little bit of history here about GaPQC. Again, absolutely just delighted to see every single person in this audience. It's really nice to see you all again. For those who are here for the first time, welcome. We have heard a little bit about the history of GaPQC, but I just want to share so we can all level set and understand what it is we're connected to. The Georgia Perinatal Quality Collaborative started in 2012. We've heard a lot of things started in 2012, right? We've heard about from the MMRC, also got reinvigorated in 2012. And the vision of GaPQC was to have better perinatal outcomes and health equity for every Georgian mother and baby. Our mission is to engage multiple stakeholders in implementing equitable, evidence-based perinatal care through robust, data-driven, quality improvement collaborative. We have stakeholders in all different parts of the state, in all different sectors, that work collaboratively to try to improve our outcomes. And I like to think of us as the action arm of the Maternal Mortality Review Committee. We've heard a little bit about the data that we have, the opportunities that are clear. And when I think about GaPQC, our job is to operationalize and implement change. We have both neonatal and maternal arms, and so you'll hear from both of us during this next couple of minutes. Perinatal quality collaboratives, you can see here, this is a map of the perinatal quality collaboratives that are funded in the United States. There is a perinatal quality collaborative in every single one of the 50 states in the nation. We in Georgia, we were early on this, and that's, I think, something for us to be very proud of, that our history in the perinatal quality collaborative world has been a long one. We were one of the 13 states who received CDC funding to support our perinatal quality collaborative from 2017 to 2022. And now there are 36 states, or as of this last summer, that were funded by the CDC to support their perinatal quality collaboratives. Together, some of the guidance that we as a perinatal quality collaborative get, and some of the resources that we can leverage, come from national organizations, including the NNPQC, NICHQ, here you see March of Dimes, and the CDC's collaborative as well. The next several slides, they're the same slides. You've seen them. I'm not going to spend much time on these at all because you've already seen them, and I will take just a little bit of liberty to talk about things that actually aren't on these slides. But these are some of the data that motivate the work from the maternal side that we do every single day. This is looking at the pregnancy-related mortality ratio in kind of 3-year blocks, and you can see that that ratio is stable. It looks like it's increasing. The data capture is a little bit different, so we shouldn't necessarily look at that as a trend. But regardless of how you look at it, this means that a mother is dying in our state about once every 10 days. And so that's unbelievable to wrap my head around. One of the things you haven't seen yet is that we know that there are disparities and they are true on multiple levels. This is one that actually highlights the pregnancy-related mortality ratio by perinatal region in our state. And so we can see that there's actually quite a big difference, and care experiences or access experiences are very different across our state. So the maternal mortality ratio can vary anywhere from 18.5 in the Savannah region to 39.5 in the Columbus region. We've heard about racial and ethnic disparities. Here's that slide again. Here's some payer inequities that you've heard about as well. Here are the leading causes of death, which you've heard about. I think it's really important to frame this around, this is how we as a collaborative make our decisions about the bundles that we want to do next. And that is taking the data to action. The timing of deaths, we've heard about that as well. These are the Georgia data about when deaths occur. And so over 50% of our deaths are occurring in that after 1 week to 1 year postpartum time period. Again, speaking to how do we help people once they leave our hospitals to be healthy when they get home. And so that is a real quick overview of those data that brings us to the action, again, focusing on the maternal initiatives here first. Over the past 8 years, we have focused on first maternal hemorrhage, and then severe hypertension, and then now the cardiac bundle. The hemorrhage is in sustainability, and the other two bundles are active. We are utilizing the AIM bundles because I think it's a nice package and helps operationalize what we're doing as an easy way for hospitals to apply. We've had quite a reach. And so when our maternal initiatives began, we had just a handful of hospitals that were participating in any initiative. And that has dramatically changed over years. This is the reach that we now have for maternal initiatives. There are 58 hospitals that have participated in one or more of the initiatives that I showed on the last slide, which is remarkable. That's not all of the 70 birthing hospitals in the state, but it is the large majority, 82%. And we're reaching nearly 100,000 births per year with these initiatives. I want to talk real briefly about some of the initiatives that are historic, and then we'll tee up the current. Our OB hemorrhage is currently in sustainability. It was launched in 2018 and been in sustainability since 2022. Some of the big, great takeaways is that our SMM, our severe maternal morbidity rate, has consistently stayed below average even during sustainability, and now our job is to make sure that we can maintain these gains. Here are some, we recently did a survey, thank you all, every single person who filled that survey out. But here are some of the words from y'all about how you had employed the hemorrhage bundle and some of the successes that you had experienced. So multiple hospitals have demonstrated hardwiring your processes when it comes to hemorrhage, which is exactly what we want to have happen. That you have consistent order set utilization, regular drills, hemorrhage carts. I love that Dr. Warren had Georgia up there showing that slide all around the country. Go Georgia, right? And then here's some quotes from y'all. The management of postpartum hemorrhage has become second nature process for the whole hospital system. Like, that's the dream of quality improvement. That's the dream of all of the things that we're doing, is that you just change how things are done and make it better. It's remarkable. So this person talked about readily available equipment and medications on the hemorrhage cart has been very useful. Another, improved accuracy in reporting OB hemorrhage case-based and QBL. And new staff really appreciate the case debriefs and having drills. They feel more prepared. I think about my learners all of the time and the change that's happened in the past 5 years and how they're like, oh yeah, QBL. Yeah, we initiated the massive transfusion protocol. Like, this is just how work is done now, and I think that that's a remarkable change. It's not perfect. There are ongoing challenges. Staff turnover, we know, has been a real issue that every single one of you are dealing with. And compliance with measuring QBL can be a part of that, which is part and parcel of having new folks in your space. Here's some data from hemorrhage. It is in sustainability, but we do continue to report on some data elements, and so this is SMM. It comes from hospital discharge data. On the left, you have the hospitals that never participated in the hemorrhage bundle. And then on the right, you have those that participated in the hemorrhage bundle. And so what you can see is that actually the people who participated in the hemorrhage bundle over here, we had a higher baseline, meaning we were coming from a space that needed more improvement. And we have had improvement. We only met goal in 2019. There's a lot going on in these years. Let's acknowledge that. But we continue to have improvement and are sustaining some of the successes we had. And that compares to the non-GaPQC hospitals, which have not seen an improvement over that time, which is it's not surprising. Hypertension is a little bit different. I think it launched right before the pandemic. I think we had a really good, strong start. And then in some ways, I think that it has not been as robust because of the pandemic experience. So we remain below baseline, but our goal hasn't been met. This is an active bundle. Significant disparities continue to exist for the outcomes for this bundle. And then from a data perspective, I have a couple things to show you and a couple of requests to make. So these are the data of, again, on the left, the non-GaPQC hospitals, and then the GaPQC participating hospitals for SMM, excluding transfusion amongst people with hypertension. And so we can see that in the hospitals that are participating in the bundle, we're better than baseline, but we're not meeting our goal. And so we really do want to be thinking about what and how we want to reinvigorate hypertension. From a disparities perspective, we're also not meeting goal. The gray bars are the race-specific baselines, and then the second bar is the change over time. So we're not meeting our goals here across race ethnicities, and in particular in our Black non-Hispanic birthing patients. These are some of thinking about like the why behind what we're seeing. These are structure measures for hypertension bundles, and the green means that that is a structural measure that your hospital has attained. Yellow is you're working on it. Red is like we haven't even started, and then gray is it wasn't reported. There were some additional structure measures added by AIM, which is why you see a lot of this gray here. But I think we can see that there are some successes here. The debriefs, the case reviews, the policies and procedures. You hospital teams have done really great work in that area, and there are opportunities in the patient event debrief, the education, and then emergency department crossing over is an ongoing opportunity that most hospitals are reporting. These are the process measures, and what you can see here, again, the goal would be everything gets above 80%, and we're falling short on most of our process measures. I think that we have to interpret these with a little bit of caution. The number of hospitals that report each quarter has a lot of variability during this reporting time, especially this last year and a half. And so some of that big variability has to do with our denominators being smaller. So I implore, if you are doing active hypertension work in your hospitals, we would really love to be able to report your data and accurately reflect what's happening in your process measures. We have a similar slide right here. These are the kind of the pragmatic timely treatment, the postpartum blood pressure check, which we know is important, and that came out in Dr. Duncan's talk. We have a lot of opportunity here. The best one that we've achieved goal actually is the magnesium sulfate treatment, but still have opportunity on all of those others. And I look forward to engaging and hearing a discussion, hopefully after we hear from Dr. Byrd and Dr. Patel, about ideas that you'll have for hypertension. And I will turn it over. Thanks.
All right, now we're going to switch reels a little bit and talk about the cardiac bundle. So you can see here, this is a slide just showing the participating hospitals, beginning with Cardiac Conditions Initiative in Wave 1 and Wave 2. So Wave 1, we began the cardiac initiative in July 2022 when we had 12 hospitals participating. In Wave 2, we have 4 more hospitals to join, which is a total of 16. But you can see we're not quite at goal because our goal is to have 28 hospitals participating by 2027. So if your hospital is not participating, we're going to implore you to do that today and kind of sign up and join the work. Oh, which way does this go? All right, so next is the key driver diagram. I know this is a busy slide, but for many of you, it probably causes a little bit of your blood pressure to go up because you know what this is. And if you do, I don't want to make you try to squint your eyes to read everything. The important thing here is to know that our goal was to reduce severe maternal morbidity and mortality related to maternal cardiac conditions in Georgia, with our SMART aim being by 2026, February 2026, which is National Wear Red Day, to reduce harm related to existing and pregnancy-related cardiac conditions through the 4th trimester of pregnancy by 20%. And so that's our SMART goal. Here we have the readiness and recognition, which are 2 phases which we focused on for the very beginning. In bold is to establish a multidisciplinary pregnancy heart team, and so that's what we focused on for many of your hospitals in just readiness, and also in all care environments, assessing and documenting if a patient presents, is pregnant, or has been pregnant within 1 year. So that's something that we really wanted to highlight in the very beginning with readiness and recognition. And these are the other areas that we wanted to focus on, some of which we'll have some more things to talk about later in the day with regard to cardiovascular screening, screening patients for acute cardiac conditions, again, establishing your multidisciplinary heart team, training all OB providers and nurses to look for signs and symptoms of cardiac disease. We also have patient and provider education on symptoms. So these are some of the preliminary data that we have here. And if you take a look at severe maternal morbidity among people with cardiac conditions 21 to 23, looking at the facilities that were not participating, you can see there that their rate has kind of fluctuated, with the goal being that you want to be below 10%. And the good thing is that we have seen a reduction, but I don't want to oversell this, right? So this looks like, oh, we're wonderful, we're great. Remember, we only had an N of 12 hospitals participating. So that means we have how many others that are not, right? And so the worry is that we have a large bulk of patients that are presenting with severe maternal morbidity and mortality to other hospitals that are not participating. And this also doesn't, I don't want to sell the hospitals that are participating like mine short. It is a win to see that, you know, the numbers have gone down. But again, we also can't wave a flag like we've won, because one of the things that we noticed and I know about is that we have patients that are our patients that deliver at our hospitals that go, and then I know of patients that have been a patient of ours that have died at other hospitals, right? And so you also could be missing that data. And if we don't have the data from all the hospitals in the state, then, you know, this data is definitely going to be skewed. So another plug to try to get all of our hospitals to participate. So this is another slide, which is really important, again, because we keep seeing a recurring theme, right? So with regard to, again, you saw reductions in severe maternal morbidity with regard to the hospitals that are participating, but now when you extrapolate it by race and ethnicity, what do you see? Again, the recurring theme that Black women, we're still not at goal and still not meeting equity there. One other plug I want to kind of put at this point in time is I also serve as the health equity liaison for GaPQC, and I'm glad to see that we have kind of drastically increase the attendance to this conference, because I think it's so important for people that provide care in the state of Georgia to moms. The other thing, but one thing I want to point out is I see a number of faces I haven't seen before, but unfortunately, I don't see as many new Black faces as I saw last year. It seems to be some of the same people that are here, and I just want to encourage us too to involve more Black and brown people in our spaces to do the work as well. I know many of them may feel like, you know, they're always doing things or they're asked a lot, but really it's important to engage us as well to make sure that we are engaging with the population that we serve, because also you will find in a lot of people like myself, a lot of people like you guys in the audience that are here, many of us are going to continue to work in these communities, do work in these communities, and have different perspectives. So I just want to encourage and implore you that even if you don't know of people in your setting, seek them out, right, to try to join the work as well. And this is the last slide of data that I have here. Again, this is GaPQC is an implementation and operations organization, right? So we want to help you operationalize all the things that AIM and these other organizations have done the research on. And what we're finding here is, yes, we've done well in certain areas, but unfortunately, those with two or three asterisks by it, those 3 categories were also some of the implementation things that happened with hemorrhage or with the severe hypertension. So we kind of got a win because we were already doing it. So I don't know that we're better necessarily, but in the areas where you still see red, so multidisciplinary case review and patient event debrief. We just saw with the cases that she presented how important it is that we do these kind of debriefs. These are areas where we really need to improve. And the other big takeaway is we still have a huge portion of gray, right? These are from participating facilities that there is a big chunk of work that's not even being reported or not being done. So that's where we have a lot of work to do. So with that, I'm going to, again, put my plug in for us to recruit more of you to participate. So if you don't know, this is the GaPQC webpage. We have tons of resources here for each of the bundles that we're talking about. This is super important. Oh, I see they did update the slides. So this is the Georgia Cardiology Referral Network. And so if you look here, the regional perinatal centers are going to be all of your black stars that are on the slide, of which there are 6. And then all of the birthing hospitals are noted as the blue H's. So the blue H's, the blue circles that are there. And then GaPQC participating hospitals are the little white circles with the red hearts. And then cardiologist locations. So these are participating cardiologists that we've recruited from from Georgia, that are willing to participate and take care of pregnant patients, whether that be through telehealth. They're willing to take care of pregnant and postpartum patients. So over 100 cardiologists that we have signed up for this. And so we've listed here, but you can see how there's a paucity of red hearts in most of the state, right? Most of it is clustered around where we are here now, right, in Atlanta, and everything else is very much, you know, a desert, right? So we need to work on that and try to recruit as many more cardiologists and birthing hospitals that we can to join the work. This is the GaPQC newsletter. So this is published quarterly. This has started coming out. It updates events, resources, opportunities, and we need your help in highlighting bright spots and also patient and provider information. So we want to celebrate bright spots. So if your hospital is doing some really great work, you can reach out to us to make sure that we get that information. Amy Mock is who you would reach out to. She's at amy.mock, M-O-C-K, at dph.ga.gov. And really, we want to be able to highlight the things we're doing here. You can distribute this to your administration, to people that you are working with, everyone, to really have them find out about the work that we're doing. Also, we listen to you. We send out surveys. Lisa Ely is really great about sending out surveys. Now Amy is helping send those out as well. And we listen to what you guys need. And so we have answered with the education piece. These are some of the webinars that we've had this year. We've had webinars, and they're every month. And the maternal echoes that you see go out, they are extremely informative. And I would encourage all of you to get your providers and your nurses to really sign up to listen to these. But we geared our talks towards what you guys asked about in the survey. This is improvement coaching. So our improvement coach, Shane Reed, who's not here because his wife just had a baby, we have an improvement coach assigned that contacts the participating hospitals and the ones that are not participating to find out, is there something we could do to help you to have better implementation, and so really walks those people, those of you at the hospitals that have worked with them, to talk you through what's going on, what do you need, are you having problems with recruitment, implementation, and really helps to pair you with resources and other people that may be able to help you in the process of implementing this at your hospital. The calls focused on the current state of maternal initiatives. 67, so 8 out of 12 successfully demonstrated PDA cycles as of March 31st. They included like physician order set usage, EHR implementation, social determinants of health screening, and hemorrhage drills. Some of the things that he also noted that were barriers were just getting people to even be interested in participating. You know, that is something that, you know, can we help with? We can. But again, these are things that, and just some people are hard stretched to have, you know, we all don't have a lot of people that work. You know, they tell us we have constraints if we don't have enough people. And so those are things that we all have to struggle with, unfortunately. But again, there are things that we can help you with, and that's what the improvement coach is here for. And here are some of our GaPQC educational materials. So as you know, we have some provider screening tools that we have, which we're going to have a session this afternoon that I lead along with Dr. Schulman, and we're going to talk about screening for cardiac conditions. And then we also, of course, have the lovely peach cards and the refrigerator magnets for those. We also have some resources for acute cardiac conditions, which many of you in the room have worked on. And again, this is a call to action. So on our webpage, you can find this information here to get you to sign up. So enrollment forms, hospital assessment surveys, and then the Georgia cardiologist practice. So those things are really important. So really go to the site and see how you can sign up and join the work. I want to applaud everyone who has worked in the cardiac work group, and I just want to take this time, if you have worked in the GaPQC cardiac work group, I just want to have you stand and everyone can give some applause, because you guys have given of your time and your efforts and your skills over and over again. These people are, you know, not paid for this work, but they have really been instrumental in getting these things like these tools, like the peach cards, out to you guys. And so opportunities for greatest impact that we noticed, especially from the calls and other things, are creating a multidisciplinary team, which we're really focused on trying to get everyone to do, engaging in GaPQC activities. So getting people to come here, I really think this is important, which is why I've had more of my residents to attend this year. I'm hoping that we can get even more of my faculty to attend as well, but really reaching out to get other providers and other nursing staff and other administrative staff to come to this meeting. Also utilizing our GaPQC Improvement Advisor, which we have a new GaPQC Improvement Advisor, and oh yes, right here. So happy to have a new Improvement Advisor on board. We want to make sure that you guys, she's going to be reaching out to you guys again. Take advantage of the resources that we have, because they're the expertise that they have and the connections and resources that they have are really helpful to you guys to help you implement this work. We also want to help you guys collect and submit your quarterly data, and of course incorporate health equity into all aspects of the work. I'm not going to go over this slide with the resources, because Dr. Warren did a great job of talking about all the things AIM, and I think there are 4 AIM resources here. I will highlight some other ones. The IHI cardiac conditions is important, because again, that's geared towards helping identify cardiac conditions in places where there is non-obstetric care, so like ERs and hospitals that don't have it. And then the CMQCC, so the California Toolkit, really a great resource. We're going to talk about that a little bit in the screening session that we have this afternoon. And then I'm going to highlight the CDC Hear Her campaign. That's another one to help people just identify, have the patient's perspective and identify signs and symptoms. Lastly, because you know our theme is all things space related and going into the future, for those of you who, some of my residents probably don't know because they're too young to know this, but from Star Trek, The Next Generation, this is a quote from Captain Jean-Luc Picard. "These are the voyages, its continuing mission to explore strange new worlds, to seek out and to boldly go where no one has gone before." Okay. And with that, I'm going to turn it over to Dr. Patel. So Dr. Ravi Patel is a professor of pediatrics at Emory University and Children's Healthcare of Atlanta, and he is a neonatal chair of the Georgia Perinatal Quality Collaborative, GaPQC. He received formal training in quality improvement through the Emory Healthcare Quality Academy and the I2S2 course at Cincinnati's Children's. He has led multiple improvement projects, including efforts focused on improving vitamin D supplementation, the timeliness of hepatitis B vaccination, critical congenital heart disease screening, care during the golden hour, decreasing necrotizing enterocolitis, and antibiotic stewardship and care of infants with neonatal opioid withdrawal syndrome in conjunction with the Vermont-Oxford Network. Dr. Patel is a principal investigator for the NICHD Neonatal Research Network, a scientific advisor to the NEC Society, serves on the executive committee for the American Academy of Pediatrics section on neonatal perinatal medicine, and he's the chair of the International Society for Evidence-Based Neonatology. So, Dr. Patel.
Thank you, Dr. Byrd, and I'll use this. I'm tall, so it's easier. Can you all hear me okay? Yep. So I'm going to give an update, and I'm going to go to kind of give an overview. I have a couple of disclosures, none specific to this talk, but I'm really honored here to share some of the work that we're doing and hoping to continue to do, and in the directions we're going on for the neonatal initiative. And I'm going to start, these are kind of the objectives for today, and I'm going to start with kind of what got us started on thinking about neonatal nutrition. And when we started, for those that are new to the GaPQC, as you heard Dr. Kottke say, the discussions happened in 2011. Dr. Levine, who's here up front, was one of those people who kind of said, we really need to have a state PQC here in Georgia. And that was formed in 2012. And so as this is spring, I thought this is a nice journey for us. We began emerging out of COVID on thinking, what was our next initiative going to be? We had spent 2017 to 2021 working, much like AIM, kind of a parallels of Vermont Oxford Network, which is a large network that's focused on quality in neonatology. And we had participated in 2 initiatives, one on antibiotic stewardship and one on neonatal opioid withdrawal syndrome, really through the support and structure of Vaughan. And we really felt we wanted to try to do something on our own that was focused on optimizing nutrition for Georgia newborns. Unfortunately, there was not any national collaborative that was established to do that. And so this took a lot of planning for us to do that, and I'm going to share kind of how we did that. Why? Well, there's an opportunity. This is when we kicked off in 2021, Dr. Kristen Marks, who works at the CDC, shared kind of our report card in Georgia for newborn nutrition. And you can see here our score was 75 on our report card compared to the national average of 81. We like peaches that are more orange in color, and so our goal is to get to to make Georgia a real orange state on our report card. What is NPINK? For those that don't know, only 50% of hospitals in Georgia submit surveys to NPINK. So one of the things we've encouraged is really to try to encourage hospitals, and if you are uncertain, please reach out to us so we can connect you with folks about getting this done. It measures practices and policies that impact newborn nutrition: feeding, education, staff skills, discharge support. And if you look at our breastfeeding rates, not only for ever breastfeeding, but across the spectrum of breastfeeding, we have a lot of opportunity to improve. And one of the things that Dr. Marks shared was there are some things we do well in Georgia. And looking at our surveys that we have done, we do well with post-discharge follow-up, with transition and glucose monitoring, documentation of exclusive breastfeeding. But and this is from her talk she gave, the areas for improvement that we have an opportunity for are things where less than 40% of Georgia hospitals had an ideal response for mother-infant separation for procedures. So if a baby has blood work, are they having to remove that baby from the mother's room? We should try to keep the mother-infant diet together. Formula feeding of breastfed infants, that was one of the areas that was identified. And I'm going to share some of the data and why we think this is a big opportunity for us in Georgia. And then written policies, which is a great thing for collaboratives, sharing policies, a measure that we can move. This is just where only about 30% of Georgia newborns had care occur in the mother's rooms for routine newborn exams and procedures. Only about 37% of hospitals had policy elements that were recommended. So lots of opportunity. And so how did we go forward? How are we going to improve? And we thought a lot about kind of what the structure should be and really focused on the model for improvement. Making it simple. One of the strengths of Georgia and one of the strengths of GaPQC is we cover hospitals all across the state that have very different capacities and contexts and support, and we wanted to use a model that's tangible for all of you that are working and your providers in the hospital. And so we followed what is widely used, which is the IHI model for improvement. So the first question is, what are we trying to accomplish? And that is always what we want to ask. What is our aim, and what are we trying to accomplish? And so we set this goal, and this is the goal really for the GaPQC. This isn't new, working on newborn nutrition, working on breastfeeding. Many of the hospitals have been working on this for quite some time. And we wanted to try to use the model to really say, okay, let's quantify what we're trying to achieve and then see how we can do that. Our goal from the GaPQC is to increase the number of newborns in GaPQC hospitals getting human milk as their first feeding from 73% to 80% by late next year. So one of the key pieces about quality improvement, it's not just education. You have to ask yourself, how will you know that a change, whether you make it in the hospital or whether we make it as a state, is actually an improvement? You saw Dr. Kottke share some of the data on the maternal end. You have to measure, and one of the key fundamental pieces is to measure how we're doing. So how are we doing? And what are some of the measures related to our aims? And how do we select them? So we spent a lot of time looking at other states that have worked on this. Most states focused that that at the time we started developing this in 2021 focused on the very low birth weight population, so the most premature babies. And we really wanted, as our vision is really to focus on all Georgia mothers and newborns. We really wanted something that could span all of the context and care in which newborns receive, whether that's in the mother-baby unit or whether that's in a level 3 NICU. And so we focused on those measures. I'm going to share those in a little bit. And we also wanted people who, we were emerging from COVID, we heard from hospitals saying we just don't have the capacity to take on something new. We wanted to also allow people to join and learn. And so for those that are here that learning, please come and learn with us. But for improvement, we had requirements about having to have champions from the hospital committing to submitting data and education. And we've really been pleased by the commitment that hospitals have had for this. And like I said, we developed this ourselves, and this wasn't something that was part of a national collaborative, and we really could not have done this with the incredible amount of support from the Georgia chapter of the American Academy of Pediatrics. Claire Eden has really been instrumental in providing the content expertise and guiding a lot of the educational content for our efforts, as well as Dr. Farrelly, who's now at CDC. So Claire, I know you're somewhere in this room. Wave so people, there you are. So the first thing is we started with audits. We weren't sure if hospitals were actually going to do the audits. And we really said we have got to try to improve the pace of testing. We can't know how we were doing 6 months ago. We want to know how we did last month. And to do that, we really changed for the first time to do monthly audits. And to do that and make it simple, where we didn't make this a measurement initiative, but we made it an improvement initiative, we really try to be parsimonious with data. And we've really had great success, over 90% of hospitals continuing to submit data. Here's how we're doing. So this is our baseline, and you could say we're stable. And what we want to become is unstable and in the up direction, and then that's our goal, is we're trying to get to 80% as a state. We really, but for the first time, we can tell you how we're doing in March of this past year, where about 72% of babies got human milk as a first feeding. Formula supplementation, and so how much formula supplementation? I was actually surprised. If you look at the data from the CDC surveys, it's about 30% of newborns, but here about half of babies are getting formula supplementation last week. I think this is a big opportunity for us to tackle. And then timeliness of breastfeeding expression within 6 hours, about 50% are getting that. So these are the 3 measures, and we want it to be broad because we know many hospitals have been working on this. The structure is to use QI tools, and really that has been use a key driver diagram. That this is what we've set for the entire collaborative. You've seen this for many of you that have been on about the interventions, but our goal, because this is such a big thing, is to give you at the local level change ideas. We've asked, and many of you have created your own SMART aims and your own driver diagrams related to specific interventions. This is for us broadly. And then try it out. If you continue what you're doing, you can see we're pretty steady as a state, 70% every month. So if we continue what we're doing, we're probably going to achieve about 70% of babies that are getting human milk as a first feeding. We have to make changes if we really want to move the needle. And that's part of our goal, is to really test these changes. I'm not going to go through this. I know this is familiar to many of you. The key is to try it out at small scale before you do broad scale implementation. And that's what we've emphasized. And about 50% of GaPQC hospitals in our initiative have talked about and shared with us the changes in processes, procedures, policies they've done. So Georgia's been busy, and for sake of time, I'm not going to go into detail with all of these, and you're going to hear some of these on our webinars when we love to share what we're doing, but some have changed their donor milk policies, how they're feeding, early lactation and education on admission. So a lot of changes that have occurred, and a few more that have occurred. So our goal is to what we think is a challenging task. I mean, this is not easy. And if you look at what other states have done, moving the needle on these measures takes a lot of effort. You heard Dr. Warren saying we got to accelerate change. And so part of that is going to be hard work, and we're going to struggle, but I think at the end our goal is to move the needle. This is actually examples of a few of our hospitals you can see on the top left. I just took these, they're de-identified, but this is actual data, and we give this back to your hospitals to see. Human milk as a first feeding, one hospital went from 20% to about 70 to 80%. Formula supplementation, 80% to down to 30 to 40%. Breastfeeding expression within 6 hours, 50 to 60%, up to 90 to 100%, and you can see also gains. So some of you are doing incredible work, and we're going to hear from that. So I'd like to give an applause to those hospitals that are doing this. Sustainment is important to monitor, and so we really have to be careful about decay, and so this is why. This is not just a short-term 6-month thing, and we've set this as a long goal. And we think we can get movement on structure measures and policies, and we've seen that across a number of policies, and we look forward to continue to see that. We're really grateful for the engagement that you've had. 32 hospitals, including 42 units, so some are mother-baby, some are NICU. 5,770 infants that you all have done the hard work of auditing and providing this data. This is not routinely collected or reported, so this is something we really had to do with audits, and over 90% of hospitals doing this every month. A lot of webinars, a lot of education, participants from 47 hospitals, including those that are not part of doing the active portions. And a lot of learning. So we've created, as part of this with Claritin's help, 24 micro lessons. These are bite-sized lessons for education. And almost 1,000 of you have viewed, 1,000 providers have viewed these to date, or 1,000 providers have viewed individually. And so this is opportunities for education. Education is not sufficient. We got to make the changes, but education is necessary to think about what changes we can do. And so our goals for this next year and a half, and I think this has continued to work. These are important aims that we want to work on, is really to start moving towards changing. And we've given armed sites with smart aims. They've developed key driver diagrams. We've given a lot of change ideas through a lot of webinars. Because this is a broad aspect, we've asked hospitals to create their own smart aims, and there's still opportunities to refine and revise that, but really now thinking, what changes are we going to make, and are they going to result in an improvement? And we really are grateful for Linda. Where's Linda? Is over there, who makes these reports, gives them back to you. There's an incredible amount of work so that you can see how you're doing every 3 months. And please use those reports as a barometer of how you're doing. You've seen some examples of centers that have moved the needle, but this is really for you to use this to say, are these changes you're making leading to improvement? Because that's our goal at the end of the day. And with that, I wanted to thank our state partners. A big thanks to Kimberly Ross, who's all the way in the back, who's really the glue that keeps everything going. Linda for data collection. Laura's not here. And then the newest member of our team, Laura Patel, who brings a lot of QI expertise, who's over here by the wall, and a huge thanks to David Levine, who got us started, who's the former neonatal co-chair, Georgia AP, and then the CDC for funding. So I think we're going to move to a Q&A session, and we'll take questions from the audience.
There's a question right there.
Hi, I'm really excited to hear about this cardiology referral network. Could you guys let us know where to find
that? So as Dr. Byrd was saying, that slide literally was updated maybe overnight, I think.
If you go to the Georgia PQC website, there's actually a link to a survey where you can enter in information to join this cardiology list.
So yeah,
I guess
what we're asking for is those
Referral.
Oh, we're working on putting it on the website. We are currently working on putting it on the website. Yes.
We know that like finding cardiologists is it's hard if you, depending upon where you are. And so just kudos to the team, because there's been a lot of work to try to get this to where it is. So apologies that we're in the middle of it. But some of the efforts that have happened is really working with the perinatal, regional perinatal centers, because each of them has a cardiologist, understanding who their buddies are, reaching out to the Georgia Cardiology Society, and really trying to think about innovative ways where we might be able to facilitate those relationships, because we know that not every hospital has a cardiologist in-house. And Dr. Ellis raised her hand because I'm sure she wants to talk a lot more about that.
No, I just thank you for mentioning that. I just wanted to let you know, too, that we're also partnering with the Medical Association of Georgia, and I think we're trying to loop our family medicine colleagues in to form really a nice statewide collaborative so that we can refer a lot of our moms during their pregnancy and postpartum periods to family medicine providers who will see a lot of those patients anyway in the more rural areas. as well as cardiologists. So kudos to our partners for working with GaPQC, GOGS, and the Medical Association of Georgia to get this up and running. Thank you.
And I want to underscore something that was mentioned earlier, but just is so important for all of us to have the messaging and to be able to communicate it to patients and families, because I think that the knowledge is still lingering of where we actually are, is Medicaid coverage for pregnant people extends a full 12 months. And so getting these cardiac referrals, we'll hear from a cardiometabolic even farther than just cardiac referrals. Those things are all covered for individuals in ways that previously didn't exist. So thinking intentionally how you can be a communicator to patients and families about that, so that a fear and just a historical knowledge that's so strong, you know, to kind of make people avoid seeking care because they think their Medicaid's going to run out. So that was a huge success. Other questions? Dr. Levine.
So is it unrealistic to think, thinking upstream again, is it unrealistic to think that we can ever move upstream and reduce the risk for cardiac disease in pregnant patients?
I'm not sure I'm the right person to answer that question. No, I really appreciated his talk, and y'all will remember, if you've been around for a while, a handful of years ago, Eugene DeClercq came, well, he was scheduled to speak, and then someone spoke in his behalf, but he and Neil Shah have an article from 2018 that, if you haven't read it, I think is absolutely imperative to understand where we are with maternal mortality and morbidity. And I think the title was something like, Maternal Mortality is a Canary in the Coal Mine. Like, we're all focusing our energies on this, appropriately so, but that upstream need is so very real. Like, reproductive age people who identify as female are just dying more. And pregnancy is that critical, like, litmus test to say underlying there's some big problems here. I know I run a teen clinic, and I have teens who have 150/90 blood pressure, and it's just like we have a lot of upstream work to do. And I do really appreciate both Dr. Warren and Dr. Duncan's framing of, we need all hands on deck here. Like, this is going to have to be multimodal in order for us to make those changes. But your question was, do I think it's even possible? I do. You saw Dr. Patel's like, impossible. Oh yeah, we can drop the M. Like, we can do this. I think people who are committed can do it, but we certainly can't do it alone. And I do think we can expand, like Dr. Byrd was mentioning, expand who and how we're partnering, and it will really take everybody. Who has something to add? I don't need the mic.
I was just going to say, too, that upstream, I think a big part of this is obesity, right? And so just like she was saying, a lot of these patients that come in don't get health care. One of the things I push to my residents all the time is that when people come for their annuals, did you send her to the bariatric surgeon? Because this lady is like over 100 pounds overweight, and at some point she's likely to get pregnant, and then we're going to be dealing with a lot of problems at that point. And we know, we've seen the 400-pound patient that walks in the door and she's 12 weeks, and we're like, what? And we know, like, we're just waiting on the other shoe to drop, right? We already know something likely is going to happen. And I will say that, you know, maybe the same way we got Medicaid expanded to a year, we're going to have to really look and see, with the population becoming more obese and overweight, look at potential funding for a lot of my patients that I refer say, I can't go because it's not covered by insurance. It's gotten a lot better, but it needs to be even better than that, unfortunately, because we can't change the Doritos and Cokes that are in the machines at school. So, I mean, we can too if we vote and get them out of there, but, you know, we got to change a lot of things. But as far as where we are, you know, maybe we're looking at, you know, paying and providing services for more bariatric care, unfortunately, earlier than later. I think they told us this was the last question, so we're going to move to the next.
Well, thank you all.